Can I call the room to order? Thank you very much. I am very sure we'll keep taking our tea as we listen. And those who have opportunity to talk, I'm sure will also be able to multitask and talk. In the interest of time, sorry for rushing you through the break, but I thought it's very important we pick a cup of tea or coffee and get back to our seats and continue with the program. We had reached a point where all our distinguished panelists had finished presenting, and now it's time for us, the participants physically here and participants online, to share their reflections based on the presentations that were made by our distinguished panelists. At this point in time, I'll hand it over to Ms. Susan to take us through the reflection session. We'll keep it so brief. I'll request we begin with a question, and then the context can come later. So let's go that way. Rather than the other way, beginning by giving you a long context, then the question comes later. Let's begin with the question, and then maybe we can have the context thereafter. We've been able to capture a number of online comments. We are going to have them projected and disaggregated according to the different panelists. So those for Ruth will come first, then those for Gato, Joshua will follow, and lastly, the ones that are meant to be responded to by Ms. Zawede will follow. So you're welcome, Ms. Susan, to lead us through the next 10 minutes at most for the reflection exercise.
Thank you so much. And welcome back from the break, although some of you are still taking your tea. Being so fast, they've given us only 10 minutes. So you should ask your questions, then the panelists will answer according. So from our physical audience, do we have any reflection, question, or comment? Yes, sir.
As I said earlier, I am Yaya Zachary from the University of Kisubi. I would like to appreciate Ruth, Joshua, and Rita for their presentations. Mine is not a question, but it is a little bit of concern that, early childhood experiences, if not drawn from back home, it's going to be a very huge issue. Because the first teachers, the first whoever you call for children is parents. Parenting has not surfaced much in that. The point is there are about 5 types of parenting. If not brought out, not handled from that point of view, you are going to miss certain things. Like there is authoritarian parenting, authoritative parenting, permissive, uninvolved, and helicopter parenting. If those are not addressed, may leave a lot of gap. When the children go to school, they get lost. Thank you.
Thank you, Zachary. Another reflection from our physical audience. Yes. There's a hand behind.
Thank you very much. I go back to the question that was framed, that are we paying attention to the mental health needs of the children of forced migrants? Also, are the children who experience violence or children of forced migrants being encouraged to share their stories, tell their stories? We know that sharing a story is part of the therapy, a talk therapy, but in most cases, children are not being encouraged to talk about what they've seen, what they've gone through, what they've experienced, during violence. I've come across parents who, when they're narrating, they say, this child actually witnessed me being raped. But I told the child, the moment you talk about what you have seen, that's the time you'll die like all the dead bodies that we met on our way while fleeing. So are children being encouraged to talk about things that they have witnessed, things that is suppressing their mental health? Also, to bring in, are we also following up closely to the changes in children's behaviors and cognitive functionalities after they've settled in, after the experience of post-migrations? Are we seeing the signs, the indicators of maybe future mental health issues and transgenerational traumas? Because if we are not doing that as counselors in the space and psychologists, then we are not doing justice to the future generation. The cases of Agu that's happening in northern Uganda, the boys that we are calling Agu, it's because we paid a blind attention to the triggers and the indicators of psychosocial and mental health issues during the post-war settings or in northern Uganda after the 20 years of LRA conflict. Thank you.
Thank you too. Another, we get them first then.
Well, thank you. My name is Christine. I'd like to ask this question to our panelists first, most especially Mama Matoya. What happens to the children, the first migrant children, who are on the street or they're in the host communities on their own that are not attended to? Because we are aware that some of them came on their own, they survived alone, some of them watched their parents being killed, and they're within the communities on their own, not attended to, having no relatives, no mentors, nobody to talk to, and some of them don't even know that programs like this exist. What happens to them? Thank you.
Do we have any other? I think the three are enough. How about the online? Yes.
Thank you so much. We've been monitoring the online conversation. We must say today has been more engaging than yesterday,
Okay.
partly also because people know that we are airing them. So one at a time. This is for Ruth. There are quite many. You have 3 slide comments, which we can share now. So if you could read them, maybe somebody in front can help us read, and then we'll go to the next. Ruth has 3 slides. We can see Joy, who is one of our donors, who was here with us yesterday. It was a thank you. And Kapuku, who is insisting to still talk, and he has been raising his hand. And he's telling us, as child protection workers, how about situation where there is demonstration in our country, children at risk of being beaten by police, gunshots, and tear gas? Julius is saying very powerful message ahead of 16 days of activism. Catherine Chiragu is saying very informative. And Sarah is saying, grow up, they want like you. I think that is also from Margaret, as you see from the slide. Yeah, so that's, I think, quite positive. And from Naki Valley, quite a lot of comments coming about parents staying in very small houses, and at night, definitely, things happen, including sex, and then the children are around them. Sexual encounters. Further, again, this is quite a long one. I think one of the chair will have to give you this is saying, how do we deal with issues of lack of livelihood, people locked at home, and children going through challenges, and organizations claim, I think this should be in quotes, that they do not have enough money to counter the financial deficiencies, and then failure to access offices, because during the lockdown, our counsellors at the beginning, I hope now it is not the case, we are not considered essential workers. And to Gato, Salongo is saying, you've been a great teacher during your days when you were English for Adult facilitator, and it's glad to hear from you again. And Grace is saying, just to remind us how we handle various children. We really need to know that children are different, and we handle them according to the difficult and individual issues they bring. Joel, who has a team of other community counselors, a World Food Program, psychiatric happens when they're on hold because of longest one in terms of text. Some people went to study counseling because of their own experiences. It's good to say that. And from a Jumani team, they're saying children now having to do stone quarry and sand selling. I think that is child labor. I think there was conversation around including that by the national learning event around child labor. So what do we do in the event that we are not able to report? And the heavy rain and people going through difficult conditions. We know that some houses are logging and they have to put tents to. What does that mean? Please go away. Parents must change the way they take their children's health. I think here they say child. And Evelyn is saying, according to the conference, a lot is desired. As you can see, what is the role of UCA and other IPs in advocating for funding in this area? I think this question adds to 3 other questions from yesterday that will be answered partly by the UCA president as well. We'll keep monitoring the chat room and we'll get back accordingly. Thank you.
Deborah, please, if you could unmute yourself, that would be great. Unmute, please. We are ready to hear from you. Please unmute yourself, Deborah. Thank you. Deborah, we are waiting to hear from you. Kindly unmute and speak to us.
Thank you so much, everybody. My comment is, thank you, Ruth, for that insightful, those ideas. I think one of the things that will be helpful as we continue working with children, Deborah Jambo, I work with children as well at Safe Haven Child and Family Counseling Center and Makerere University. And one of the things we are doing now, which I think is very helpful for us as counselors, is doing research and hear the children themselves. We've got involved in studies as Makerere University and AfriChild to actually hear the children's voices. What are the children saying during COVID-19 about their own mental health, so that we are able to build evidence-based practices. I know we have a lot of needs for children, but being able to capture what the children are saying, I think is one area where we need to grow as well as counselors in this country, so that the interventions are tailored towards the children's voices as well, and what they need at the moment. There are so many experiences they've had, which I don't want to go into details, but I'm hoping that as an association, as people who are interested in children, we'll be able to listen and read some of the preliminary findings coming up from these research studies. For example, the children were telling us when we were collecting information from them during these research projects, they are staying home, like Ruth is saying, they are growing very fast, and they are concerned about how people are treating them. They are concerned about how they'll be affected when they get to school. Some of them, of course, are in child labor, and how that is affecting their mental health. They are the ones looking for the money. They are the ones struggling with being able to provide. So they've grown up faster than what they ought to do. And then there's increased depression as well. And what they're doing, actually they're very resilient on how they are managing and what needs to work best for them in their settings. So I'm encouraging us to be able to dive into doing more research and then be able to use evidence-based practices as therapists in this country as we design interventions and work with the children. Thank you so much, everybody. Have a great day.
Thank you very much. They are joining us via Zoom. Over to Susan to wrap up the session. Thank you.
Thank you, audience. Indeed, today has been more active than it was yesterday, and we are happy for that. So back to our presenters. We are giving each of you 2 minutes to respond to the people's reflections. We begin with Ruth. May you please come.
A lot has been said about how do we hear the children's voices, because their mental health is linked, mental health welfare is linked to whether they are able to express themselves if they have experienced adverse abuse and other unfortunate incidences. I noticed that we can be able to give them the voices. Many of us are in a position to do that, but after we hear their stories, we need the skills to help them process those stories. It does not stop at just telling the story. Something must be done after the story has been told so that the child can live adaptively with the information or with the experiences that they have had. They will not forget, but they will learn to live adaptively with it. And that calls for all people that handle children to go an extra mile to learn on how to intervene with children, because telling their stories, there are very many avenues. We can do that, but what we do with the stories is the most important thing. We also noticed that caregivers on both sides of the divide are negatively affected by the situations they are in, whether they are victims of forced migration or just normal parents. And they have serious deficits in enhancing the mental health of their children, even when they are charged with giving the primary mental health care. So I think another thing we would do is begin to deliberately and seriously take care of the mental health, the primary mental health caregivers. When a mother has been raped, she's suffering shame, and she will not be in a position to respond to her daughter's shame. So help the mother, help the child. Projects have to be done. Increased funding. Let's not wait for just the donor organizations to do that. There can be simple volunteerism in the communities. There can be support from the schools. Teach the teachers. How many of you have volunteered to go and teach about trauma in the primary schools the children go to, so that the teachers understand what trauma does to the children, so that even when they educate them, it will be trauma-informed education, not just results. And lastly, I would like to say that research is a beautiful place to go, and using the results of the research, we will be able to get funding to get to the community. I quickly want to answer 2 questions. One person says, what happens to the child in the refugee camp who has no father, no mother? He arrived because he followed a team. The people on the ground, I'm sure, are trained to be able to intervene at the basic needs of the child. After that, it's important that they are placed in good foster care so that they can be helped to integrate, however, even if they are lonely, integrate with the community and given continuous support. Again, the question, how many people do we have out there who have the skills to deal with that? So everyone, food for thought is for you to get an extra training on how to handle children of forced migration and their mental health needs. Susan asked, who is a backward child? Because one of the things was mental health has to be taken care of and the backward child must be helped. A backward child lacks education, lacks the basic life skills, lacks etiquette and basic manners, lacks knowledge and the practice of basic self-care, along so many things that they cannot live adaptively within the communities within which they are. Therefore, that child must be helped. I wish I could answer more questions, but I only have 2 minutes. Thank you very much. Thank you.
Thank you, Ruth. Now we understand what a backward child is, and thank you for the other reflections you've addressed. So we call upon Joshua to come and take on.
Yes, I want to thank the audience for being attentive, because if you are not attentive, you cannot be able to ask a question or to give a comment. Thank you so much. I will first react to the comment of our sister there who talked about storytelling in the therapy of children. It is the ideal and it is the best practice, because for us in our Hero's Journey program, we have approaches we use. We have games, we have stories, we have play and art. In the stories, we have what we call sand tray. We provide sand trays to every child in a program with multitudes of toys. Then the child will create their world in the sand tray. Then from there, we will encourage with encouraging questions to encourage the child to tell the story from what they have created. Like the way Mrs. Matoya has said, telling a story for the child, telling a story is one thing. And what do we do with the story? It's another thing. So if we find a child whose story is traumatic, we identify this child for special psychosocial support through one-on-one. And we do it holistically, not with the child only, but also with the caregivers, parents, and foster families. I like the comment of our brother from Kisubi, the University of Kisubi, who talked about involving parents. That's why we use a holistic approach where we take parents through psychoeducation, teaching them the symptoms of the trauma in children and many things, so that we can work together to provide psychosocial support to this child. And there is a question somewhere, someone asked, what are the symptoms of trauma in children? This part of psychoeducation I'm talking about, there are many symptoms and they vary according to the age group of the children. A child of 3-4 years exhibits symptoms which are a bit different from a child of 15 and 16. However, they cut across. For children of 2 to 5 years, you will find them showing signs of fear. They cling to their parents. They cry every time. They move aimlessly or they freeze up. They regress to earlier childhood behavior such as thumb seeking, sucking, or bedwetting. It would be very shocking to find a child of 5 years who has gone back to the symptoms, to the behaviors of a child of 2 to 3 years. So, but these symptoms, we consider that they are of trauma if they have persisted more than 2 weeks and above. That's when we say that there could be a problem. 6 to 11 years, they lose interest from the activities they used to have. They have nightmares, they have also sleep problems. They become moody, they struggle with school and homework. They complain physically, like headache and stomachache, but in actual sense, if you find out there is nothing like that, they develop unfounded fear, they feel depressed, emotionally numb, they feel guilty over what happened. Yes. So there are many symptoms. We cannot exhaust them in this presentation. It is a broad topic that can be exhausted through a different forum, like in a training, specifically in psychoeducation part of it. For adolescents, 11 to 17, they have flashbacks, they have nightmares, sleep problems, they avoid anything which can remind them of the traumatic experience. They also start abusing substances like alcohol and smoking. They are too disruptive, and you find them isolated. They don't want to play with others, and so on. So those are some of the symptoms, but the way I have said, we don't look at them just 1 day or 2 days. We call them symptoms of trauma unless they have persisted for more than 2 weeks and ahead. In the interest of time, I want to thank you for your attentiveness, and thank you very much for your comments and questions. May God bless you.
Thank you, Joshua, for that insightful information you've given us. I think we have a lot to do as the carers to learn more about managing children. It's not a simple task. We need to know how to interpret the stories the children tell, the kind of play they do, so that we understand them well before we can help them. Thank you, Joshua, for that. Now we call upon Rita and her colleague to come and take us through their reflection.
Privileged to be here. Now we are talking about what Rita shared about SCE, early childhood experiences, and we are responding to some of them. We are under Shared Love Uganda, and this program, as Rita shared it, has got one snag, that the research she presented is from the US. So what is really needed is research based on our own experience, our children's experiences in this country. We need to pick that up. And with SCE, we have programs. We have training in communities and on radios, particularly Namirembe FM, and there's Masaka. And we are so privileged to have these programs because the response is quite encouraging, actually overwhelming. Because after the talks on radio, people ask questions. Then we have also arranged trainings, workshops in Masaka, and we meet these people. And we also are fortunately, many of us in this group, if not all of us, are counseling psychologists. So we meet people one-to-one, and we also meet some in groups. One of the concerns brought out here was parenting. We have a parenting program. We normally want to engage caretakers and parents, sorry, my mask. We involve people in these trainings, parenting. I think Rita can talk about UCA, maybe. What can UCA do? One of the things that we are looking forward to is to engage UCA, and we train every counselor in UCA so that
adverse childhood experiences are taken everywhere. We want it to be a ripple all over Uganda and beyond, because the nation, an upright nation, stands on an upright family. If the parenting is wrong, the family will be wrong. So it's very important that UCA responds to this SCE training program so that we can give away this knowledge to you people who we know that you are the right hands to handle this. And about the radio programs, it is Namirembe FM every Saturday from 12 noon up to 1 p.m. Please join us and send your comments. And then on Impact FM, it's every Monday from 9 a.m. to 10 a.m. So you are very much welcome to that program.
Masaka.
Yeah, that's Masaka.
Okay.
It is Masaka. That is Masaka on Monday. Then we've done trainings in the Eastern, in Barara, Masaka, Central. A lot is being done in Central. So something is being done to see that SCE is known. We also help people to process their adverse childhood experiences. We don't only stop at training, but we also help you to process. It has a 12-week program, and it's very good. People have really thanked God that they joined that facilitation program. Thank you very much.
And we are very grateful to UCA for involving us in this program today. Thank you very much.
Thank you, Rita and colleague. You are doing a great job out there. We've heard. You are promoting child well-being on using media, which not so many of us are doing, although UCA as an association is also trying. But when we get individuals in your own capacity with your organizations and you go out to promote such programs, it's really very healthy, and we appreciate it so much. I was bitten by the pyramid when you were discussing about the SCE experiences from conception to death. I only remembered the pyramid when I was studying of Maslow, basic needs. But then when I found it here, it really beat me down. I feel I should get to know more about it. Thank you so much. Thank you, our audience. Maybe my colleague can come in and usher in another group for another session.
A round of applause for Ms. Susan and the entire panel for the work well done. Thank you so much, Susan. Ladies and gentlemen, next we have another panel. This panel will be chaired by none other than Joan Anena, who is the staff of Refugee Project, and I'll right away invite Joan to march forward. As they march forward, I would request that we stand for a minute and stretch, before we get into the next panel that is going to look at issues around health services. So as the panel settles in, kindly just around your chair, ensure that your neighbor is safe. Let's not hurt our neighbors, but it's important that we stretch. Thank you. I'll right away hand over to Anena Joan, who will do the due diligence of introducing her panel. Thank you so much. I think we can resume our seats.
Good afternoon.
Good afternoon, ladies and gentlemen.
I appreciate your presence both online and in the physical space. My name is Joanna Nena. I work with Refugee Law Project, and I'm also a student of mental health psychology counseling at Uganda Matters University. The discussion has already been framed, and it's taking shape in understanding what it takes to attain a healthy mind in a healthy body amidst COVID-19, with focus on forced migration, mental health, and gender. And we know that it's obvious that we can't talk about psychosocial support without engaging the health care services. With me is a team of great panelists who will be shaping the discussion on health care services in connection with mental health and psychosocial well-being of forced migrants. On board we have the DHO of Kirandongo, Mr. Motabia Iman. We also have a representative from St. Mary's Hospital, Lacho, Dr. Julius Meyer, and we have a representative from the Office of the Prime Minister, Mr. Robanda Izera. Not to waste more time, I will take this time to also invite on board Dr. Motabia Iman to share with us or shape a discussion on the district's health center's capacity for refugee mental and psychosocial support and the challenges and the prospects at large. You're most welcome.
Thank you, Joanne. Good afternoon, everybody. I'm Dr. Mutiawa Imam, not Imani, but Imam. I am very privileged to be. Please allow me to observe protocol. It's a big privilege to be here, rubbing shoulders with the gurus in mental and psychosocial support. What has transpired in the last 2 days is that the mental health and psychosocial services have been grossly minimized, very marginalized, despite the fact that we have a big need. And what I'm going to say, is that I will just share with you what are the challenges, what are the gaps, and do we have any opportunities for improving. Kiriandongo is one of the districts in Uganda which has the biggest number probably of ethnicities. We are talking about over 70, and that gives us its own challenges, but also opportunities. Despite being multi-ethnic, it is a host to over 67,000 refugees, with a population of about 320. It is one of the settlements which interface with an urban center. In Kiriandongo, we talk about whether there is a settlement, the refugees have settled all over the district, which actually lends credence to what was shared yesterday. As we talk about mental health for forced migrants, we forget that these people are staying among populations where they reside. COVID-19 actually clearly showed out the gaps that we had. However, what is the background, what is the district
role and responsibility. The Minister of Health and Partners developed an integrated response plan. I'm glad my brother from the Office of the Prime Minister is around to share with us as a way of background. The IRIF, the Integrated Refugee Response Plan, was meant holistically look at the health of both the host as well as the migrants, the first migrants who are our refugees. You cannot talk about, you can't talk about mental health and psychosocial support without starting with the health. It's like talking about health. Of course, health has a lot of confounders, social determinants. That's why one of the comments that was made, that in Kriandongo, reduction in the food ration has had a psychosocial impact on the refugee children. That, before I forget, that means we must start thinking about a multi-sectoral approach towards dealing with mental health, as well as we have that multi-sectoral approach towards health. So we already have an integrated refugee response plan, which is in consonant with the health service provision, meant for the health service provision in refugees, and is in line with the health policy of our country. The integrated refugee plan in our district, which is a very big positive, has already been aligned to our development plan. We are trying to look at mental health, but you cannot look at mental health before the actual health of the populations, including refugees, is concerned. This RRP is looking at how we can improve equitable access to service for both the host community as well as the refugee community. Now, I have already, the district local government, as I said, is mandated to take leadership, oversight, and all the stakeholders are considered partners in the provision of this plan. The local government is also meant to look for more resource mobilization as we move. Now, what are our challenges? Our challenges are majorly, as the district health system, are related to the building blocks of the health system by WHO, which looks at, actually, we have a mismatch between the actual service delivery and the gaps and what is realistically what we should have. Yesterday, everybody applauded. I think I was one of the people to applaud when the director clinical services from Ministry of Health talked about the restructuring process that is going to bring a counsellor at a district. Can you imagine? The current restructure that we are talking about is about 20 years ago. Now we are talking about having our first counsellor at a district hospital, as if we don't have psychosocial and mental challenges. So you can see, the district cannot take lead if its own structure cannot accommodate these critical cadres. The same thing goes with Okay. You can, so we can say already we are talking about 80% of the population experiencing mental issues. The district health system, by design, as I already said, though we have already a plan, a comprehensive plan, the current resources in place are not in consonant with the task at hand. I've already said the district hospital can only have 3 psychiatric nurses: a clinical officer, a registered nurse, and enrolled nurse. And that is the referral facility meant to look at the mental and also psychosocial support for the rest of the district. So you can see a mismatch in the task. As a result, because of the other blocks of the health system, the refugee population of 67 is looked at by 3 health facilities. One is Health Center 3, and 2 of them are Health Center 2s. Again, a mismatch. The resource allocation is according to the level of care. So it means that we are going to lack supplies. We live in a world where inadequate infrastructure, because these facilities are lower than their actual level of care. We have lapses. As you see, I wanted to show you the biggest number of cases, the big proportion of our mental cases who require psychosocial support is epilepsy. Epilepsy is very rampant. It almost contributes 3/4 of our cases. Yes, but you cannot, you lack the psychosocial support to look, the network is not there for them to be able to look after them. What are the prospects that we have? We cannot sit down and cry. Kiranongo is lucky that we have a very welcoming people. My chairman is here, can attest to it, that Kiranongo is one of the most hospitable people, and therefore has created a very favorable environment for the forced migrants. We have built strong collaboration. One of the such collaborations is the Refugee Law Project, which has now brought a psychiatrist and several other critical cadres, including radiographer and the gynecologist at the hospital. That's the meaning collaboration that I'm talking about. As we move forward, can we start thinking at how we can bridge the gaps? Because the hospital, beyond seeing the refugees, is also seeing the other host communities. To me, that's synergistic. We also have had, COVID has highlighted psychosocial gaps in our systems, and as a result, there is a heightened need by every stakeholder to start thinking about mental health and psychiatry. And as I talk now, we have already, before the Service Commission, a card of staff in the name of a psychiatric nurse. So we think we are now moving. We are now working on, we are thinking that we can also look, I've already alluded to the IRP. It's already a document that we can use as a stepping stone to improve not only our health, the health of our people, but also the mental health of our clients. I had some pictures of what is there happening, but what are the recommendations? We need a new shift, policy shift, to bring out mental health and social support as a critical health problem. And it reflected in the structures we are talking about, in the resource allocation, if we have to move in the right direction. We need to review the current structures. There must be a corresponding funding to bridge the gap. The district, we are looking at mental health programming to be prioritized as the district, the partners to come in and support. We need to support strategic health information, research and innovation. That's one area if we have to get people to support us. We have to revisit the essential medicine and supply for refugee hosting facilities because they are unique facilities. Provision of adequate infrastructure, improved coordination. That's one area, especially for the players and who are doing work in mental health and psychosocial support. I've already alluded to a multi-sectoral nature of collaboration. Health was invited here, but mental health and psychosocial issues have to do with community health and other players and education. I thought those are critical issues that we need to think about. In conclusion, mental health is a big health problem that unfortunately majorly partner-led because the government still have not given it a lot of attention that it deserves. A good mental health would require to be coordinated by the district and the partners would follow. I want to thank you all. And I want to thank the organizers who invited me. I can assure you, we are not going to be the same. It's not going to be work as usual. Thank you so much for listening.
Thank you very much, Dr. Imam. Can we give another round of applause? The key points that I've taken from its submission is the need for multi-sectoral approach. I remember yesterday when Dr. Chris was giving its submission, he talked about how counseling alone cannot be the answer to mental health and psychosocial well-being. We need a multi-sectoral approach where we invite all the actors. Now, also another one that has also hit me hard is the fact that he talked about the 60,000 refugees being hosted in Kirandongo and the 70, he says over 70 different ethnicities. What does it mean? We have been talking about the multicultural approaches to counseling, multicultural approaches to service provision. I think this is the time to kickstart and look deep into these approaches. And also he talked of how after 20 years of advocacy and pushing, now the Ministry of Health is bringing on board a counselor at every district, at every district facilities. Meaning we don't need to give up on advocacy. It might take time, but when we keep on pushing, it will actually reap some good results at the end. The next speaker is Dr. Maya, from Lacho Hospital. Dr. Maya is a medical worker who has been working with Lacho Hospital for 4 years now. He will be sharing with us a personal professional experience in serving forced migrants who experience physical and psychological and psychophysical war-related injuries. And he is going to expound on the fragilities for refugee patients. Dr. Maya, you're most welcome.
Thank you, everybody. All protocol observed. A lot has been said. Much as time is against us, I'll be slightly a bit specific to some of the points I want to put across. I said a lot has been said. Refugees, they are like any other patients. From the presentation you'll see as I go with, you'll see that most of the conditions that refugees have, even our patients have. So refugees are not like unique in terms of conditions, however, in some extent. So for my personal experience with refugees, I've learned refugees, one, they're very cooperative, two, they have issues with languages. However, the most conditions that we have like post-traumatic stress disorders, discopathy with neuropathy. We also have foreign body and osteomyelitis, foreign body osteomyelitis, like the bomb blast. These people have been tortured, they have been affected with wars over wars. On top of that, when you look at discopathy, you find like these clients of ours, they have been tortured, they have been carrying heavy loads. And so you find like if you look at the nerve roots for the clinicians, if you look at the nerve roots, you find mostly the lower back pain, the lumbosacral regions. We have the nerve roots to the lower limbs. So you find most of these patients have discopathy. The lumbosacral regions are always affected. They also have issues with the lower limb pains. So those patients, they always have discopathy, neuropathy. On top of that, you find like these refugees, you also have elements of gastritis, pancreatitis. Look at the way they feed. Sometimes they don't feed, sometimes they eat once in a while, so they have issues with ulcers, which is also very prominent with our clients, the refugees. And leaving alone that, we also look at elements of UTI and PID. For most men, they tend to have UTI, and then for females, we have like UTI together with pelvic inflammatory diseases. However, you find like these clients, they have been for very many good years without attending any health checkup in their body. So they are first encountered, you find they have a lot of issues. And also with hygiene, coping up, so they have issues with UTI, pelvic inflammatory diseases. So leaving alone that, we also have issues with them like HIV infections. Some of them, not all, but at least there's some aspect. They have infection, and also to access the drug is also another challenge. So complications associated with HIV infection, they are also there. Much as we try to work on it, but really they have a lot to be helped in that regards. And also hypertension and diabetes, not so much prominence, but there are also aspects of those people. Because when you look at the way they also feed, the stress they undergo through, so you find like, hypertension, much as if you look at hypertension, stage 1, stage 2, stage 3, some of them come when they're already in stage 3. So you have slightly to work, counseling, and try to look at the adherence onto drugs. And then also lipomas and hernia. When you look logically, you find like these patients, because of the trauma, the tortures, they have like some body swellings. When you examine, you find it is a lipoma and hernia, like for men that have been carrying heavy loads, the abdominal muscles. So you find that they have the hernia. Could be the left inguinal, right inguinal. The supraumbilical hernia is more common in females. And then also when you look at the chronic hepatitis B, Because when you look at hepatitis, so if you are really to make that diagnosis of chronic hepatitis B, you find like for them, they really come at a later stage. So they also have elements of chronic hepatitis B. Infertility, you find like these clients, they are always tortured, they are always raped, they start sex early, so you find they are also prone to infertility issues. That's what you have seen with what? With some of the clients. And then when you look at some of the possible few challenges we have seen, like poor adherence to treatment, you find we also have issues with language barrier. So some of them, seeing it is their first time also to come to the hospital, first time to be checked, so their understanding of the drugs, that the drugs works, is also a problem. So it makes their adherence also a challenge. Also, on the other aspect, you look at the issues of food. How can you take drugs when you are not eating well? So they have also that issues. So we still have those challenges with the refugees. And then also the poor hygiene, then counseling as well. And then some of them miss appointment. So the reason why they miss appointment, because some of them have tendency of easy forgetting, so they don't know when they're supposed really to go. So they also have that challenges of missing their appointments. And then also another aspect is sometimes you find like there are very many clients to be taken for review at a particular time. But also look at aspect of transport. You find maybe the transport these people have can take like maybe about 15 or maybe 10 plus, so the other balance will be left. So it also affects elements of adherence. That's what I've seen with them. And then also in other aspect, in my recommendation, I think these people also need really financial supports, because much as we said, what if finances are not mobilized? So you find really these people, we cannot do much. You find like most of these investigations, they have to be paid, the drugs, like patients, because now when we look at patients, we have patients on chronic drugs, chronic medication, chronic condition, so they really have to adhere, they always have to take drugs in time. So we need really to mobilize for them the financial supports, and also counseling as well, because when we look at post-traumatic stress disorders, a lot has been said. You find some of them have been raped, tortured. So in that aspect, you find these people, they always need to be counseled as well. Much as we are giving the drug, counseling is another aspect. So it also plays a big deal. And then also engaging these clients of ours into small income generating activities. Much as they're always being given food, but ideally, what they're being given is also not enough as a human being. What you are being given, sometimes you need other things. So these people should be engaged into small income generating activities to supplement on what they're being given. And then also need for health educators. So these people, seeing some of them, it's their first time to know about the health condition, their first time to know that certain condition need to be treated, so we need health educators who could really help these people. I think I don't have much to say. Thank you for listening. Then another thing I want to put across, I think on behalf of LACHO, we really thank the funders of this project. We really fund the Law Refugees projects, because we have really also seen that without the Law Refugees project, I don't know how these refugees would be. Because you look at patients, chronic condition, patients who need drugs, they need to be transported, they need food, they need accommodation, they need translators, they need all sorts of things to be helped. From the camp to the destination, from there back to the place, organizing, review, follow up, and then the NENA and the team, we really need to thank these people. They are doing a lot. I've been with them, they are really doing a lot. So thank you, thank you, thank you, thank you.
Thank you very much, Dr. Julius Meyer. Another round of applause. I can see it's coming towards lunchtime, and the enzyme might be working. And to our online audience, you can keep the comment coming. The technical team will be able to put it on screen at the time of our reflection. What I've picked is the need for interpreters at the health centers. We know there are very many different languages that are being spoken by the refugees, about 36 languages. So if they are not well interpreted, then there will be issues of misinterpretation and misinformation as well. And at that, we also give back the credit to RLP for English for adults, that is then helping refugees to be able to speak for themselves when they go to hospitals and health centers. Also, another thing that was mentioned is the need for nutrition. Some of the clients that are actually being transported, they will have issues that requires them to eat certain kinds of food. But what we know that is being given to refugees, it's mostly maize and beans. And for patients who have ulcers, we know how that reacts. So it still comes back to the different actors. How do we support? Next on board, we are going to have Mr. Rubanda Ezra. He works with the Comprehensive Refugee Response Framework Secretariat at the Office of the Prime Minister, OPM. He will be shaping a discussion on psychosocial well-being as a key to the realization of the CRRF. You're most welcome.
Thank you, Madam Chair, colleagues in the House, and those online. My name is Ezra Rwanda. I'm here from Office of Prime Minister. I was informed that I come and we discuss the issues of well-being and how psychosocial well-being affects the success of CRRF in Uganda. Madam Chair, when we visited one of our settlements a few months ago, we were challenged by a case where two people were fighting, and then one injured the other on the head. Then examinations went, and time reached for prosecution because this person, the medical report was clear that his brain was injured. So when they went to court, this person was told that you injured someone's brain, you should start to prepare and go to jail. He raised and said, what did I injure that you injured the brain? How many brains does this person have that he has one? And then he asks a question. How sure are you that by the time we fought, it is not this brain, the sick brain, that actually triggered the fight? Of course, if you were the judge, what would you do? The man had his case. It implies that where do we base ourselves to say so-and-so's mental health is okay, the other's mental is not? I am bringing this to the practitioners. I'm told these are counselors, and they have all the tools to measure the status of our brains and their functionalities. So that triggered me into trying to understand, this is how we hold it in the refugee response. What is well-being in our view? We don't know the view, and that's why I'm here. I want to learn the view of the so-called counselors, the psychologists, the experts. But it was in refugee response, we think that if this brain, the outcome
output from the brain, the functionality of the brain, if it can shape positive functionality of an individual intra and inter. Because sometimes, no one, maybe you know them. If you ever asked anyone that, are you okay? They all say yes. But to you, you say sometimes that they are not okay because you are experts. But to them, intra, within themselves, they sometimes say they are fine. So to us, we are looking and we are thinking that it refers to the intra and inter-individual levels of positive functioning. It includes self-referent attitude and one's relatedness with others. So that's the approach of the sick and the ill. When you are sick, when you feel you are ill, then when the other people feel that, observe that you are not okay, that's when they say he is sick. So we think that for us, we are looking at it from that perspective. And it affects one's sense of mastery and personal growth. Our underlining aspect here, we are looking at personal growth, the growth of this individual affected. You cannot come and say, I am here, I'm growing, then that's not life. So to us, in refugee response, we are so much concerned about this personal growth, the person's growth. And it is understood by studying one's emotional being, social behavior, and the collective well-being. There are those people, you are trying to push them to this line, and for them they are saying it is supposed to be the other side. So we are trying to look at it from various perspectives, different angles, different lenses of looking at this. Because it's not just a mimic of psychosocial, because we are very good at coining terminologies, and we don't want to see inside what these terminologies are all about. But I just wanted to share the perspective of ours in the refugee response. The context as we speak right now, where do we lie with the refugees? This is the statistics that we had by June 2020. You might want to say, hey, we are in December, this man is sharing 2020. I want to share with this house that if there is anything that is very hard to study, ascertain, and contextualize is psychosocial status. Where does it lie? Do we have a continuum, agreed continuum, that if you measure to this, then you are more sick than the other? Maybe the professionals can be of help. But these are the statistics that we've got. I don't know whether I need to go into the specific ones. But what is common, and I would want to share with this house, Madam Chair, lies on this one. I will come back to the microphone. Since the outbreak of COVID, this is where we moved from. We were at what? We were at 17. Now we are at 108 by June. These are the cases, and we are trying to see the association. Agenda. When you wake someone up in the morning, you are not the cause. The cause is the sun coming. But this person, if they are adamant, they would say, why are you waking me up? Hey, boss, you can't, even if you closed your what? Your house and you're in darkness, but still the sun has already come. What I'm trying to say here is that our system for psychosocial agenda was not that robust, neither the best. So that we now blame COVID entirely. Let's treat COVID as a what? Just a signal. And then we go back, that's when we'll be able to address a comprehensive system that does this. Now, CRRF. CRRF has got 5 pillars. These pillars, the first one is about admission and rights of the refugees. We've got a challenge that we cannot have that sustainably done if the people we are working with are in a psycho-social state that is not well. Because this affects the self-determination. Because even if you were coming from the heaven with all the resources, and you're trying to move people, there has got to be that internal enthusiasm that propels the individual that we are trying to support. So, Madam Chair, I can see the time is not on my side. And then we are talking about emergency response. When these people come, we try to run and support them. But if we play that we had them in a better state, when they are coming and others are collapsing, it means that the response, the intervention for response ought to be more complex than we would think if they were able to move the way we would want them to move. Then self-reliance and resilience. This is where it touches most. When these people come, we would want to support them. And indeed, there is a lot of partners who are trying to support them. But the support keeps melting on a rock day in and day out. You go and give them seeds, nothing is happening. You go and give them this, the other day they are fighting. So what we're trying to say is that psychosocial well-being is very important and a very big pillar for the success of self-reliance and resilience, because there is no amount of support you can give these people unless they start to support themselves. They can't support themselves unless they know they have functionalities that are well coordinated, both intra and inter-social dynamics. Expanded solution. This is an objective or a pillar of CRRF where we are saying that once people are here and they can have other alternate ways, we call them third countries. Please let these countries receive them and they host them as well. And countries are willing. But there is a screening that is done by UNHCR to qualify some and leave others. For those who are exiting into third country, what is normally there? They want to check how do you have cases, how stable are you as a character, how do you behave. Now that means that this pillar cannot work until we are presenting, I would think, normal and progressive people. Run the next slide. Then voluntary repatriation. This is a pillar that looks at how we can help these people to go back, especially after skilling them, after orienting them, and they are positive in terms of their... Now, what are we doing? Yes, since yesterday we are talking about problems, highlighting problems. Now, at CRRF, one of the approach that we have done, the CRRF, for those who do not understand, there is a steering group composed of development and humanitarian players, government, academia, media. They sit every 3 months in a hall like this one, and they deliberate on issues of refugee response. Now, this matter of psychosocial challenge has come to their agenda, and they guided, number one, that studies be made. Comprehensive studies. We are basically now, I'm very happy that we have colleagues online, especially from academia. We are basically dealing with something we don't understand. You can't think that a person aged 23, you met in a refugee settlement, and then you say, I am going to work on her and make sure that she becomes okay. No. We are trying to say, can we try to find out why? For instance, there is a triggering question. We have got around 12 are refugees from around 30 countries. But this challenge is so prominent in South Sudanese. You are the experts. The question is why. there is a set of people, hypothesis, they hypothetically think that maybe South Sudanese have had civil strife for long than others. Yes, it's a hypothesis. Some of you could follow that and give us a conclusion. There is another group of thought who say it's about what they feed. Yes, you know that how you feed matters in terms of your brain capacity. Then another school of thought is saying that it could be weather related. That these guys are under high scorching sun compared to other people. So we are asking, if we removed South Sudanese and, for instance, brought them to the central, would this reduce? We don't know. And that's what we are putting across. So we are making sure that comprehensive studies are being done. Funding is also being pronounced from government of Uganda. We received last year support from government of Italy and government of Netherlands. And this project is one of the beneficiaries to that effect. Madam, I'm concluding. Then the last one, another one we are trying to say, the SG directed that whether you are in livelihood, whether you are in health, in education, wherever you are, because so far we have got 5 response plans. Whichever intervention you come up with, it must embed aspects of psychosocial support and mental health, because the situation is getting out of hand. Then we have got, we had an intersector meeting after that, where all those I'm talking about sat down and we say, how do we take it forward? For them, they said, Minister of Health guide us with UNHCR, and we come up with a psychosocial, mental health and psychosocial strategy. Now, on that matter, Madam Chair, allow me to call upon stakeholders in this conference that please jot down what you think works, and we put it in this strategy. Of course, it's going to have consultative processes, but I wish you could jot it down and we get the strategy to support this agenda. House questions? The first question is psychosocial system thesis and antithesis. Should we, if we are designing interventions, should we bring back because the system, we believe that there is a community system that was looking at these issues, because the incidence of psychosocial problems back in the community where this person came from was working, because he did not have that. So should we, if they are South Sudanese, can we go back and borrow what they were doing back home in their communities, those social systems of working against such a kind of traumas and problems? Or when they come here, because they are in host communities, we simply make them adopt what works in the host communities. Or we bring the other one and mix with it and make a hybrid. Or we abandon that and we say we are going formal, where we employ 1 million counselors who just deal with the situation as is. So these are a lot of hypothetical questions that we need to answer with you as professionals. Then the other question is about the targeting. This is where the biggest challenge lies. Normally, public health looks at the community as a whole, and they design good programs, take them to radio, go and distribute nets, and we get it. But the problem with psychosocial is medical. You deal with an individual to an individual. On that matter, I will entertain more discussion issues, and I wish to say, for God and my country.
Thank you very much for that wonderful presentation. What struck me was the analysis of the 2020 suicide data. Actually, it gets back to us as practitioners, psychologists and counselors. The terminologies we are using, psychosocial support. What is inside? What is the ingredients inside? And the question of what were we doing before COVID-19? Did we do anything to improve the lives of forced migrants? And now that COVID-19 has even hit harder, what are we doing? As we take some, I'll take about 3 from the physical audience here. Reflection, as the technical team will be working on some of the submissions from the online audience. He also mentioned that trauma affects individuals differently. So assumption of because someone has experienced violence, you assume the person is traumatized. And therefore what the person needs is counseling. We need to work on our assumptions and go with what's real, the reality on ground when it comes to working with forced migrants. So I'll take 2 of the submission. Yes, can I have some help?
Friends, I want to sincerely, with profound gratitude, appreciate the presenters. Nothing to subtract. Most importantly, my senior DHO, Chiradongo. My name is Manga Godfrey. I'm the acting district health officer for Adjumani. Adjumani is one of the districts in Uganda hosting very many refugees. Actually, the second highest number, about 214,000. Very close to Yumbe, that hosts the largest number in the country. Our refugee population is about 48% of the total population of the district, which is about 450,000. Now, COVID and mental health. Allow me to say this. Adjumani is contributing about 200,000 of COVID confirmed cases of Uganda. But it is among the first districts to register positive cases. Actually, 2 days after the first case was detected on 21st March, I think it was a Saturday. Adjumani's case was on 23rd. At that time, COVID was a bit rare. Geographically, Adjumani is located of West Nile, but administratively we belong to West Nile. Our regional hospital is supposed to be, but because of distance, we prefer referring to Gulu, Lacho and Gulu referral. So on 23rd, when they confirmed that case, the news came on 25th. None of the referral hospitals were willing to take that case. Good enough, we had prepared to respond to Ebola, and then we used the facilities established for Ebola to manage that case from within, and successfully healed on 14th of April. At the beginning, majority of the cases were refugees. Actually, 90% of the cases at the beginning were refugees, but later, now majority are Ugandans. Actually, the total refugees are 53. The rest are Ugandans, numbering 143. Our total cases are 197 as of last evening. The last pillar of CRF is about voluntary repatriation. This pillar is actually being implemented in silence. Refugees are crossing South Sudan, and then back freely. And this was the main cause of most cases being refugees. You remember South Sudan was hit more than Uganda. Number two, of course, porous borders, they were sneaking. And when they will be intercepted, they will be managed a little bit hastily. And this was affecting their mental health. They will be quarantined for 14 days. So anybody be tested positive among the quarantined persons, again, they increased 14 days. To the extent they started escaping. They were cutting the fence of the institutional quarantine and then escaping because the trauma was getting too heavy for them. Now, the challenge I wanted to bring regarding COVID is when the guideline changed for case management. Previously, if you are positive, you are tested twice before you are discharged, and both test results must be negative. When Uganda entered phase 4, where so many transmission occurring in the community, the guidelines suddenly changed. You now you are admitted either home or in a center where they treat these cases. 10 days, if you don't show signs and symptoms, you are discharged without laboratory test. So these discharged persons go home without test certificate. Previously, it was very easy to integrate these discharged patients because they will even produce their negative results and they will be accepted. Integration was easy. The biggest challenge we have now is they are being rejected. In fact, the 197 cases.
I request that you wind up.
I'm winding up, sorry. Of the 197 cases, 40 are health workers. Just the other day, one was a laboratory technician. He was discharged, he went home, but he didn't have the negative result. He went to fetch water, they locked the borehole for 2 days. And there was chaos. What I'm saying here is counseling is inadequate. Why? The committee responsible for counseling, the psychosocial support committee of the district task force, is poorly funded. Previously, it was big. It was led by District Community Development Office. It was a big team. Because funding was not coming, they contributed their patriotism voluntarily, without pay. Later on, they pulled out. They left only one mental health nurse, who, when was on leave, was when boreholes were being locked. Because he's a human being, he needed to rest. He went on leave for 2 weeks. It was when now they discharged patients without certificates, and they were being rejected. And the trauma level of a rejected person is very high. I thought I should say this to supplement on the presentation. Thank you.
Thank you very much for that submission. Dr. Chris' hand was up. Can we hear from him?
Thank you very much, and particularly thank you, Ezra, for coming from CRRF. What is UNHCR's position? Unfortunately, they don't come to these kind of functions. So where do they see Ugandan civil society organizations fitting in MHPSS? I think we have many colleagues in the room who have not been directly involved in humanitarian settings, so they're maybe not familiar with the whole business about implementing partners and operational partners. But from where you sit, what is the vision of UNHCR and OPM in terms of the role of civil society in delivering on what I think you've acknowledged is a massive task? Thank you.
Thank you very much. I will go online. Let's take the last from Lady so that we balance gender.
Thank you so much. Thank you, our presenters. Mine goes to, it's a concern to Mr. Rubanda. I'm just asking whether on that team, the strategic planning team, you have a psychologist among the members. I feel it would be relevant if you had one, because we have a lot to offer, as in promoting the intra and social dynamics.
Thank you very much. Let's listen from our online audience, the technical team. We shall take 2 comments from the online audience, and then we call it.
Yeah, thank you so much. From the online team, the following have been recorded. I think they will be general to all the people up there. Sister Kajuna is saying the Ministry of Health should be involved. I think yesterday Dr. Olaro was here, so maybe the participant wasn't there, but yeah, definitely on how counselors can be involved in the healthcare facilities. I think this is around recruitment of interpreters and counselors in the health facilities. Given that we have district leaders here as well, I think that is a talk to them again. And Jackie is saying, for far too long, Uganda Counselling Association have been talking about passing the bill for counselors. They're still waiting. Again, Mr. President, I know you're on my left-hand side. Please prepare that as well. And Paul is saying we need to educate parents on the 3 stages of development, the oral, anal, and phallic stages of development. I think this is very psychological. I think if Paul is listening, the question is who should do it? I think this is a question that we will send to the panel as well, but for all of us to be talking about. But also a conversation around the medic saying currently mothers seems to be doing bottle feeding instead of breastfeeding. And that seems to be affecting the mental health of children as they grow up. I think this one, given that we have doctors in front there, they will be able to attend to that. From Ajumani, they say this is for the organizers, that we need sign language interpreters subsequently. And for other people who are also here, but also with us online, Elizabeth Okello, and saying partnership is important. And for those who have partnered with the district hospitals, Mr. Mutiaba, thank you so much, and thumbs up, as you can see there. And Baldi is saying cases of maternal and neonatal death should be addressed. The question also how, and maybe how that is connected, I think that is up there. Some counselors are saying COVID-19 has definitely affected the way we do things, even spraying of the podium. I think it is virtually affecting some people watching as well. And Joel from Kiriandongo is saying, thank you so much, St. Mary's Hospital Acho, for treating our clients over this period of time. Lamwaka is not holding awards and saying the issue of poor drug adherence. Some experts in the client community linkages should be recruited. So maybe the health center will be equipped with a number of people as well with community linkage facilitators. Edohu did not hold his words and said, for a paradigm shift in the refugee strategy. For far too long, refugees have been treated as commodities over whose heads experts haggle ideas that in many cases paper over the cracks of broken refugee system. I'm not sure who will answer this question, but definitely you can see it is right from that angle. Otherwise, thank you.
Thank you very much. I'll now give 1 minute each to the panelists to respond to the question as we wrap up.
Fine, I just want to talk issues of the bottle feeding, which they have asked. What I've also realized is that, you see, when we talk of health education, health talks, it is not simple like the way I can say it like this. It is slightly big. Because when you look logically, when you look at a child is supposed to be exclusively breastfeed for about 6 months. That is the ideal way to go. But you find like we have like mothers, we have the working class and those people who are at home, their ways of looking into that is different. When you look at aspect of cancers, like the breast cancers, ideally when you look at the breast, you find like all different ladies or women have different sizes of breast. But when you look at the fats, so you find like if a child is not breastfed for about 6 months, so you look at the fat, the quantity of the fat, it's so much. But exclusive breastfeeding for about 6 months, and then maybe after 2 years, another child like that, it reduces on the fat onto the what? Onto the breast. So it also reduces onto the risk of somebody getting the breast cancer. So health education, to me, it is paramount. So it is good we have the district health officers here. So I feel like most of the gap that I've seen in villages, and even together with our client, the refugees, we really need to put emphasis on what health educations. the food people are eating is bringing a lot of problems in them. They don't know how much to eat, when to eat, at what time to eat. So we really have challenges. Thank you, thank you, thank you so much.
Thank you, Madam Chair and the audience. One clarification is about what my brother from Juman highlighted on, about the movement of refugees across the border. What I highlighted in the pillar is voluntary repatriation, and this is completely different from voluntary movements. This coming in and going out, in and out, it's an illegal practice, and we condemn that. Once you come and you're a registered refugee, and you feel at any time you want to go, you go to the registration authority and apply that I am going back, and you are given a moving certificate of going back. When you're coming back fresh, you come under new terms and conditions. Yeah, it's okay, you can go 1,000,000 times, depending on the situation, and coming back. But if it is official, is what we call voluntary repatriation. The question is about the concern about that. I'm very glad that this is being mentioned, that in some districts, psychosocial committees are elected, but the challenge is about financing. I would want to assure you that the strategy we are trying to develop, part of its responsibilities is to mobilize resources. Because right now we are there, but resources, as I said, they are up. Italy is giving us resources, the Netherlands, the government of Uganda, but these have got to be channeled through a systematic, institutionalized kind of functionary. But it's good, it's being highlighted, and we're going to put it to the agenda. Number 3, the vision of UNHCR and OPM in respect to the implementing partners and operating partners. This is a good question, but I need to shed a thing that UNHCR or Ugandan refugee response needs partners in millions. So what is being done right now is to try to put up a mechanism that is harmonized and will reduce duplication. At Office of Prime Minister DOR, they have designed a platform which, once you apply and you want to join refugee response, you are pressed there. Anyone, anytime can come and say, Agency X is doing business D, and in a locality called Y, and the agency is being governed by so and so. So it's about information tracking, and you cannot be in one house when you are not synchronized. So that is what we are trying to do, and more people or responders are welcome. So that the vision is clear and positive. Last question or response, Madam Chair, is about, is there a possibility that a psychologist could be invited to join the team that is working on a strategy? Yes, completely yes. And I think if you happy to join, please channel your information through Mary, who has been our coordinator. She will be able to link this to me, and then we extend official invitation. And we are very happy to have you on board, including the Uganda Counselling Association. So otherwise, it is a continuous struggle. I thank you very much.
I think I can say I'm very happy, and I think this is a very big starting point for us to improve our mental and psychosocial services in our district. Thank you.
Thank you very much to the panelists, to the online audience and to the audience physically in this space. As we go back, what should be ringing into our mind? I will be thinking of mainstreaming mental health and psychosocial support in every project or programs that involve forced migrants, and also the multi-sectoral approach to service delivery. And also working on the referral pathways and networking with other partners or actors. Just like the same mental health well-being and psychosocial well-being, cannot only be attended to or cannot only be worked on through counseling. We need to network and develop pathways. Before we close, I'm told there's one pending question that they would love Mr. Ezra to respond to before we close.
What is the question, Madam Chair?
Sorry, yeah, it's right there. I think there is, from the chart, it's saying, for a long time, we keep talking about refugee-centered approach, holistic approach, whole of society approach. So I think it is going to the CRF Secretariat. Ezra, over to you. Thank you.
I don't pick the question. What are you asking?
I think the person is asking that for far too long, refugees are being treated as commodities, as kind of properties whose experiences, experts in quote, researchers, policymakers like ourselves, ride on in terms of ideas and get papers, including maybe research papers. And they're asking, how do we move the refugee discourse to a refugee-centered approach, putting refugees in the heart of it, not just using their own experiences, that other people get research papers and presentations and PhD books. Thank you.
I get it now, but I find it completely subjective. To begin with, yes, the refugee response in Uganda is progressing. Yes or no? The answer is yes. Where is this progress coming from? It is innovations and designs and redesigns of the intervention that we make. So when you say that people are taking chance of certain situations, I would think it is sort of out of context, because when an agency comes and does research, to begin with, or the point of concern is what you are presenting as facts. Are they facts? Yes. And is this public information? Yes. When you misuse this information, the problem does not link to the refugee response, it links with the use of the information. I don't know whether I'm making sense. Now, as a country, as a policy, as a government, what is our position on one, collection of information or gathering of data and use of this data? The new approach of CRF has brought in the play the key information or data holders called UBOS. And UBOS has come up with what we call standard operating procedures for conducting any form of survey, of research, of dissemination of whatever form. It is giving a process. And they are supposed to be the key custodian of this information. So that's the attempt we have put in place to solve that kind of challenge. But when it comes to the information, it has, again, a connotation to do with rights. When Ezra comes here and speaks, what he speaks have a connotation with his rights of speech and rights of publication. So, for that matter, I would want to think that this could be a subjective issue, but still the mechanism to organize refugee response and information sharing has already been put in place.
Thank you very much. With that, we come to the closure of the session. I will hand over the mic to the day manager. But as he comes, I still say, do not open wounds that you cannot close, or do not leave the wounds that you have opened bleeding, leaves it bleeding. In counseling, we say, when you open a wound, try as much as possible to ensure that that wound is closed. It goes back to storytelling. After the story, then what? You are not supposed to go and just be collecting data, listening to stories for your own consumption. How about the person who is telling the story? In what state are you leaving that person? It goes back to networking, partnership, collaboration, and referral pathways for proper referrals and support. Thank you very much.
Thank you very much, Joanne. Let's give them a round of applause and as they go back to their seats. It's been another long session, but very, very insightful, provoking lots of conversations, both online, but also physically. It's only time that is limiting us, otherwise we would have lots and lots of conversations going on. We're supposed to get to the next session, the seventh session, the seventh panel that brings on board duty bearers in this conversation. And this session will be chaired by Devota Nue, and it brings together a representative from police, and this is Hajat Aisha Kayongo. We'll later have a discussion from the Ministry of Education and then the Judiciary Training Institute. But looking at time, we've been told that lunch is ready, and according to our program, lunch was supposed to come at the tail end of all these discussions. So we are requesting that you pardon us, we break off for lunch and then return and complete the remaining load. Is it something that is agreeable to all of us physically and our contributors and participants online? We request that you pardon us so that we don't have to wait until after all this presentation to have lunch. We are cognizant that among us we have people who have issues and they can't wait for that long. So we're requesting, is it something that we all agree? Or you still feel we should push on and have lunch at once? Can I hear some voices? What do we do? Wow. It's been unanimously, I want to agree that it's been unanimously agreed that we go for lunch and then return and complete the remaining load that we have. So our online audience, we request you to have some 30 minutes off, depending on where you are, have a snack, have something to eat, and then we are resuming in the next 40 minutes. So kindly, let's try to keep it 40 minutes, so that we return and complete a little earlier. You know, being the last day, it's a very tricky day. There are people who might be thinking of traveling far. So I kindly request that we try as much as we can to keep it to 40 minutes and see how we proceed. I will request a volunteer to bless our lunch. as we go to partake of it? A volunteer? Thank you.
Stand for a prayer. In the name of the Father, and of the Son, and of the Holy Spirit. Almighty Father, we thank you for this day. We thank you for a moment and the sharing. And so, Father, as we go to partake of the lunch, bless the people that have prepared it, and let it be a blessing for nourishment as we get through the session. Bless all the people who have prepared it in the name of the Father, and of the Son, and of the Holy Spirit.